Hello, everyone. Thank you for joining us this afternoon. I'm Chris Essel, and I'm so pleased to be leading the team here at Southern California Grantmakers. Now and for the duration of this crisis, SCG's mission in response to COVID-19 is to mobilize philanthropy to respond rapidly, effectively, and equitably. We do that by fostering inclusive collaboration, learning, and bold actions. We hope that today's conversation helps you do just that. Before we begin, which I'm sorry we were a little late getting started, technical difficulties, I want to quickly provide you with an overview of the work SCG is doing during this time of crisis. We're working closely with our partners in Northern California and San Diego Grantmakers under the banner of Philanthropy California. I highly encourage you to go to that website. We've assembled a comprehensive set of resources and analyses. You can find a link to that site in the chat box. Every Thursday morning at 9, we hold a weekly funder briefing, which is designed to provide high-level overview on specific themes, such as nonprofit resilience, or in fact, this morning, public health. In between these weekly calls, we are convening members by sector, by county, and by issue areas. Some of our briefings include open invitations for the nonprofit sector and your grantees to join. Our work will continue to adjust and morph during this crisis as needed. Our team stand ready also to help you answer your questions, track down additional resources, and provide any other support you might need at this time. This morning's funder briefing, as I mentioned, was on topic of public health, and we are very pleased to be able to continue this conversation this afternoon by learning about the response efforts in LA County specifically. We are still experiencing this as an urgent public health crisis. We know philanthropy stands ready to complement and enhance our local and state government's response to this outbreak. This afternoon's conversation is designed to help you do that. I'm now going to turn the virtual mic over to my two esteemed colleagues, Dr. Robert Ross, President and CEO of the California Endowment, and our now rather renowned Dr. Barbara Ferrer, Director of Public Health for Los Angeles County. We know how precious your time is in this moment, so we extend our gratitude to both of you for joining us today to share your insights with the nearly 300 participants who have signed up for this session. We'll spend the bulk of the hour with the two of you in conversation, and then we'll open it up to Q&A. To those of you who are joining, please feel free to add your questions to the question box at any time during the call. With that, I will turn it over to Dr. Ross, who will share a high-level view of the endowment's response and then transition to his conversation with Dr. Ferrer. And she'll provide an overview of the latest information on LA County's numbers and its response to this crisis. Dr. Ross, take it away.
Yeah, can you guys hear me okay, Chris?
Yep.
Great. Thanks, everybody. Apologies, it was my end on the technical difficulties, but got worked through it. So yeah, just really appreciate your leadership, Chris, and Southern California Grantmakers and everyone who's leaning into this crisis in whatever ways they can from a philanthropic perspective. At TCE, we're into phase 2 of our response. We issued a $5 million quick emergency response to local funds that have been stood up to respond to the crisis. Such as the California Community Foundation and other Community Foundation colleagues, the United Way and others. We're now into a second round of funds. We're about to announce another round of $12 million into the coming months from the board that will be a bit more, hopefully, strategic and surgical around where the gaps and needs are, particularly facing the most vulnerable communities. So we'll be doing that, and like many other foundations, trying to provide our grantees with as much flexibility in terms of the grant dollars they now have. So we're doing that as well, and we're in a conversation about our PRI funding as well to see if that can do anything. So with that, join me in welcoming the now famous Barbara Ferrer. And Barbara, you know what? I knew you when before the world knew you. But there are a couple of different ways to get famous. One is through a scandal, and the other is in the management of a crisis. And I'm pleased to say you're very much in the latter category. I have Barbara's bio here, and Barbara, we've known each other for a little bit. I actually never read your bio until preparing for this interview. And reading your bio reminds me there was a show back in the 90s, I guess, called In Living Color with the Wayans brothers, and there was a skit with a Jamaican family who always bragged to each other about how many jobs they had. You've had a lot of jobs, my friend, and you come well prepared for this leadership role, not only running LA County Public Health Department, but a well-known, nationally known public health leader with 30 years of experience in philanthropy at the W.K. Kellogg Foundation as a strategy officer. She led the Boston Public Health Commission. She was a headmaster at a school. Um, she's worked in chronic disease prevention, in maternal and child health, and she's got a couple of master's degrees in addition to a doctorate and and a Bachelor of Arts. And I don't know whether any of that education has prepared you for the last month that you have just experienced, Barbara. So I just want to say thank you for your leadership. And first of all, how are you doing? How are
Yeah.
you getting through it? Is it yoga? Is it meditation? Is it medical marijuana or vodka? How are you getting through the crisis of stress that you've been weathering for the past month?
Yeah, thanks so much, Bob. And truly, like I know, I've been thrust in a position where it's been very public, but I hope everyone knows, there's thousands of people across this county that are doing a lot of work to help us get through what really is a devastating pandemic here in LA County and really across the world. And I can be a spokesperson at times during the day, but I rely so heavily, not just on the amazing team that's here at Public Health, but more importantly for a pandemic, on the amazing work that all of you are doing and all of our residents are doing. Everybody who lives here. I mean, this is not at all possible for us to be effective in a single thing that we're trying to accomplish, which is really to slow the spread. Without enormous sacrifices, often from the people least able to sacrifice. So I want to note the disproportionality on what was being asked, what is being asked, and who's bearing the brunt of this pandemic, which affects all of us. But unfortunately, I think for some individuals and certainly for some families, it's had a devastating impact and continues to have a devastating impact every day. So I'm so glad I'm here in LA. I feel like this is a place where people actually try to do their best. But I also feel like this is a place where a lot of people are hurting and hurting really badly right now. And not just in terms of the health impacts, which are horrendous. Every day I have to stand and talk about people who die, and the numbers go up every single day. And behind the numbers of people who die are people fighting for their lives. And behind everyone fighting for their lives, there's a whole bunch of people risking their lives because they're essential workers. And then there's all the people who are out of work. There's all the people who are home when they have a home, trying to stay safe, oftentimes in spaces and places that weren't meant for the intense confinement that we've asked people to adapt to. And then we have a lot of people here in LA County, 45,000 people, that have no place to stay home and be safe. So this is a community that's been asked to do a lot to try to, as we say, flatten the curve, slow the spread, so that we get through this with as little loss of life as we possibly can, and with our healthcare system intact and able to continue to provide much needed services, not just for people who are infected with COVID-19, but people who need healthcare services across the board, people who have cancer, young children who need to still get their life-saving immunizations, people who get hurt and need to go to the ER. So I want to acknowledge so many heroes. I'm not really one of them, who are giving their all to get us to the other side. And I know we're going to get to the other side, but I don't think it's going to be easy. And I don't think it's short. Like, I don't think the other side comes tomorrow or even in a couple of weeks. I think it's going to take a while. This is a pandemic because none of us have any immunity to this virus, except for the people who now have been infected and have recovered. And that in LA County is still a relatively small number. So there are lots of us who can both become infected easily still and can infect others. And as a matter of fact, some of us can infect others without even knowing that we're infectious, because it turns out that you can be asymptomatic and spread some amount of this virus. I don't think they're the biggest spreaders or the most productive spreaders, but they certainly can infect other people. So that, you know, we're in a space where it's universal precautions. We don't have enough testing for everyone who needs to be tested, and those are mainly symptomatic people to get tested. We certainly don't have enough testing available for asymptomatic people to get tested. So it really means we have to walk around our day for many days to come, understanding that anybody we're in contact with can infect us, and that we, unfortunately, can be asymptomatic and infecting others. We have a host of tools that we use when we don't have vaccinations, when we don't have therapeutic medications, but they require this enormous sacrifice. They require us to, in fact, tell people, stay home, don't go to work, close down retail establishments that aren't selling essential goods, don't have people congregating at all the events we love, and the events that actually enrich us all, you know, cultural events, sporting events, religious events. You know, we're in the period that one of the holiest weeks for many faiths, and you know, we've told people you have to stay home, can't celebrate communally. This is so hard on everyone. But it's all we have. All we have right now are the tools of maintaining our distance from each other, and that's significant. That means at least 6 feet apart, not intermingling, so trying to stay with whatever household you are in, and just being part of that small group of people, unless you're an essential worker. Now when you go out, we're telling you to please cover your face with a face covering, and that means your nose and your mouth, so that you don't have your respiratory droplets, unfortunately, hit another person, infect another person, or a surface that another person touches. Asking all of our essential workers to do the same, use face coverings when they're at work now, so that they too can protect other employees and the public with whom they interact. And then telling people in a very with very significant implications, if you're sick and you have respiratory illness, you have to now act as if you have COVID-19. Don't wait to get tested. If you have mild illness, you need to isolate, and you need to isolate for a long period of time, at least 7 days, and then you have to have 3 days that you're symptom and fever free before you can go back out. And that means isolate from even your household members. And then you have to identify all your close contacts, and those are your close contacts that go back 48 hours before you were showing any symptoms. And you have to ask all of them to now quarantine for 14 days, because it's a long incubation period. It takes full 14 days before we know whether or not you who had an exposure are going to, in fact, develop symptoms and potentially infect others. This is asking a lot. These are our public health tools, though. Physical distancing, now covering our faces, quarantining, and isolating. And we don't have anything else in the toolkit at the moment. So if we all do this and do it well, I think we see the kinds of results that we're seeing right now, which is we're not seeing a very steep acceleration in the number of cases every day. We're seeing an acceleration, but it's not the kind that would overwhelm our healthcare system. We have about 8,000 cases of people who are positive with COVID-19 here in LA County. We've doubled the number of cases over 7 days. When we first started seeing an increase, we were tripling in 6 days. So we've slowed that part of the acceleration. But about 22% of people who are positive end up in the hospital. And once in the hospital, somewhere between 20 and 35% of people are ending up needing to use a ventilator. and they're often in the hospital for relatively long lengths of stay. It can even be a couple of weeks. So you could see how if you just do some of the math, if we're not careful, we do overwhelm our healthcare system. You know, every person who's infected on average can infect 2 to 3 others pretty easily. If you don't get that number down and you start multiplying, you'll see how quickly we hit 1 million cases here in LA County. So the job
Hey, Barbara, can I
Sure.
Yeah, let me pick up on that point, because you just gave, in about 11 minutes, you just gave Public Health 101 to several dozens of colleagues here in philanthropy. I see attendees 208, so maybe it's that many people. But take us to, you wake up in the morning, you're on point for tracking this horrific and unprecedented pandemic. What are the 3 or 4 or 5 things that are top of mind in tracking how we're managing with this pandemic? That's sort of question number 1. And question number 2, on the optimistic side, and I don't want to get overly optimistic, this is not a time to declare mission accomplished, way too soon, of course. But we appear to be, in California generally, and LA in particular, we appear to be faring better than what has happened, and certainly what has happened in Italy and what is happening in New York. So that's my way of asking, is physical distancing working? So what are you tracking, and what optimism can you give us about physical distancing?
You know, we're tracking primarily information about people who are infected and what their trajectory might look like, understanding the serious limitation we have around testing. But I do look at the number of new cases. I do look at the number of people who are hospitalized every day. I look at percent increases all the time. You know, sort of how much are we increasing these numbers? How much of that increase, particularly the number of cases, is directly correlated with increases in testing capacity? We're paying a lot of attention to ICU admits and intubations, you know, people who are needing to use ventilators, because that's a resource issue. I'm looking all the time, as is everybody else, on how much personal protection equipment we have. You know, you can't really ask frontline workers to take all this risk and then not give them the equipment. So, you know, that's another really important piece of this, is making sure that people who are doing their jobs have what they need to do their jobs well during a pandemic. And one other, you know, critically important piece of information that we need to do a better job on being able to track is around the implications around race and ethnicity and poverty. And the reason why I say this is like vitally important, and we have to look at these numbers every day, is I personally will be ashamed if this ends up being another example of disproportionality among people of color, and that we did nothing about it. We tried to do nothing about it. We didn't even bother really getting the information we needed to better understand it. You know, preliminary data indicates that African Americans are dying at a significantly higher rate across the country from COVID-19. This has nothing to do with personal behaviors at all. There's no evidence to suggest that this happens because our African American neighbors, brothers, sisters, friends are in fact behaving differently than anybody else. It has a lot to do with the roots of disproportionality amongst all kinds of health outcome data, starting at birth, when Black babies are 3 to 4 times more likely to die in the first year of life, and at the end of life, when our Black residents are also dying 8 to 10 years earlier than most other people. And it's really associated with racism and discrimination. We have to call that out, but then it's not enough to just say, like, this is what happens when you have a broken system and now you're in a pandemic, which really exacerbates, from where I'm sitting, all of the cruelties around disproportionality. So this is a disease that actually affects people who have serious underlying health conditions. 83% of people who have died in LA County are people who had underlying health conditions. And if you look back and you see that African Americans, Native Hawaiians, Native Alaskans, Native Americans, American Indians, are much more likely to have higher rates of all of these chronic diseases that can so impact your trajectory if you become infected with COVID-19. It's pretty easy to sort of draw the line here and see the disaster that's looming in front of us if we don't do everything we can to try to address the inherent inequities that are in place. So, you know, I struggle because we don't have really good data on race and ethnicity, and that's problematic, and that may be something that philanthropy can actually help us with. You know, really prioritizing the importance of collecting this information. And it's often hard to collect this information when the very people who we ask to report to us have experienced such profound discrimination that they're often very reluctant to provide this information with fear that it's going to then somehow even make it harder for them to get access to the things that they need to be healthy. So we have to address that. But we also have to understand that the disproportionality isn't just on the burden of disease. It's also on the burden of not having all the other resources that we need to sort of weather the next 2 months. So disproportionately higher rates of poverty, disproportionately likely to be in lower wage jobs with less protections, so less ability to get paid or told to telework, more likely to be working in these frontline jobs where that's why we have to make sure people have protection. You know, you can't ask people to do all this work and then not provide them with protection. But that issue of disproportionality, we have to get better at understanding it. But more importantly, right now, we have to get better at fixing it so that it doesn't have the consequence of continuing to create these gaps in health outcomes that we can try the best we can to avoid.
And certainly throwing in housing as well is one of those determinants. Barbara, thank you for raising the issue of where racial equity and health equity meet. You just described pretty well that intersection and what it looks like. Getting back to the issue of let's comparing New York and LA for a minute. Have we been lucky or have we been good?
I think it's probably both. You know, I definitely want to, you know, huge shout out to everybody. You know, we get these Google Analytics and they're limited, but they're important in showing us, you know, what changes in our behavior have shown up because of all of the requests for people to do this physical distancing, and we look good. You know, people are really have really made significant changes in the way they're behaving. You know, the sort of going to the hiking trails way down, you know, recreational facilities that are where groups were gathering way down, retail obviously way down, restaurants way down. So the good side of, you know, sort of us doing the distancing, I think people have taken that to heart and really, you know, doing their very best. But I also think we're lucky. First of all, we're lucky because we've had the opportunity to learn from what's happened in other countries and in other parts of our country that came before us on getting hit harder. And, you know, every day we learn something from the experiences in Singapore, in South Korea, in China, in Japan, in Italy, and in New York City. But we also have benefited from, we have a very different way of living our lives here in LA County. New York City, it's about 8 million people in a tiny, you know, relative to the 4,000 square miles here for LA County, you know, much smaller footprint. And people live their lives every day in much closer proximity to each other. Most people in LA County drive their own cars. It's exactly the opposite in New York City. Very few people in New York City drive their own cars on a daily basis, but almost everybody does use mass transit. You also have a lot more very big, tall, you know, apartment buildings, which means elevators. You have people are often living in smaller spaces because of it's a city, and people end up being in a tighter configuration with other people for all facets of their life. So I don't want to say, you know, we've done so much better than New York City. You know, our folks really rallied. I think folks in New York City are really rallying. I think the circumstances under which they find themselves are very different than ours. So you could call us lucky, or you could just say it's different, and that difference probably has some advantages at this point, given that this is an infection that really likes for people to be close together to spread.
Yeah, yeah. Hey, Barbara, I'm going to end this interview with a question to you about specific opportunities for philanthropy. But before I get to that question, and then after that one, we'll open up the conversation and questions from the audience. But so now take us to the federal policy perspective for a moment. Public health officials and experts have been warning us for a long time about the lack of pandemic preparedness. You and I both know, having worked in public health departments, that public health department budgets have been excoriated over the years, going back to the Reagan era. This well predates President Trump. But what are the 3 or 4 things that our federal policymakers and the White House must do to prepare ourselves better? What should we, as from our standpoint in philanthropy, a lot of us fund policy work, research work, advocacy work. But what if we really learned our lesson from this thing, which I'm not sure we will. I hope we do. What will we do differently in the years ahead?
Yeah, it's a great question. I'm not sure I have the right answers for it. I mean, I have some thoughts. One is, you have to have a consistent investment in infrastructure. If nothing else, the tools I just told you, the 2 of the most important public health tools are the ability to identify cases and then to identify close contacts with people. And in this case, also do institutional investigations. I'm probably one of the only health departments in the entire country at this point where there's been a surge in cases that's maintained any capacity to do those activities. And it's only because I'm one of the largest health departments, and I've redeployed hundreds and hundreds of people to do case investigation, contact tracing, and institutional investigations. I literally think we have over 700 people that are doing that work. Most health departments don't even have 700 people in the total number of people that they have. And yet these are the primary tools that a public health department would need to do to actually try to slow the spread. You have to be able to identify cases, and then you have to isolate people and quarantine close contacts. Testing, if we don't have testing capacity, I mean, it's unbelievable that we don't have a federal policy on how you would actually be able to ramp up testing in real time so that you could actually help, again, identify cases, which would really help you do the isolation, do the quarantine, prevent unnecessary exposures. But that's all an infrastructure issue. The second piece that I think we absolutely need to grapple with is more of a policy piece. We're one national country, but this is very localized and state determined responses. And that can come back to haunt us at the end. So I would suggest that we take a hard look at sort of, how do we hang together as a country? Because issues around stockpile, issues around access to ventilators, issues around surge capacity, those are mutual aid issues always, and that needs to cross boundaries. So the situation where we're all competing against each other, counties competing against counties for scarce PPE, everyone competing, states competing against other states for the ventilators, we should never be in this place again. This is a horrible place for us to be as a country. This fighting any kind of pandemic requires enormous collaboration and cooperation. These viruses, as we all know, they know no boundaries. So to not have the national ability to address these essential capacity issues as a country, I think is a very flawed. It's been a very flawed approach, and it will hurt us over the long run, not just in the short run. It's going to actually hurt our ability to recover in the long run. And I think the third issue that I would say at the federal level we need to pay more attention to is access to good information, and then being able to widely communicate that information to all of the different sectors that really rely on having really good information to make their own decisions. So one huge gap, as I noted, is the absence of good information around race and ethnicity. But there are other really big gaps here as well, including the fact that there's a huge disconnect between public health departments and electronic medical records, for example, and health information exchanges. You know, it's a nightmare right now to be able to try to collect information we all need every single day, and we're really doing it manually at this point. And that, again, you know, we needed to have a federal policy that fully integrated public health and healthcare way back when. You know, this is not the time for us to be on these complementary tracks. This was the time for us to be fully integrated around sharing information, and then that would allow us to share appropriate information more widely with individuals who live in our communities and the different sectors that need to be able to make decisions around planning, both for responding to a pandemic, but also for the recovery.
Absolutely.
I'll stop
well, from your lips to Congress's ears, Barbara. In addition, of course, I know you well enough to know you would agree on this. Failing to have a national policy on health for all,
yeah,
is a way is a matter of pandemic preparedness. Let's shift now to any thoughts you have for us in philanthropy, and then we'll open it up to any questions. You mentioned PPE already. There was a mention about race and ethnicity and data collection, but does anything that we should be thinking about or doing around PPE and other equipment that hospitals and medical centers and clinics need? How bad is that situation?
Yeah, I think the situation's really bad, and you know, but I'd like to step back from sort of what we need to what I think our communities need, because I feel like there's a lot of us trying to figure out how to get PPE. We obviously could use all the help we can. I think it's really a federal responsibility to get this PPE. The federal government has to insist that we have the manufacturing that's needed so that we have this equipment. It's not really a dollars issue. It's not having a supply chain, both on the testing at this point and also on the PPE. What I probably would plead with you all is to help those that have been hurt the most by all of the measures we're taking. Those people that are unemployed, those children that aren't able to connect to a e-learning platform easily, that are going to miss their 2 meals a day when schools aren't open. Those families that are trying to struggle to care for a person with disabilities because caregivers have disappeared and they have no funding. Those folks that, as you noted, are going to be facing devastating consequences to not being able to pay the rent. And I know, you know, there's a moratorium on evictions, but if you lose 3, 4, 5 months in wages and you still have to somehow back pay all the rent, and you were already marginally earning enough in a living wage situation to pay your rent, you can see that this will be devastation down the road that we ill can afford in LA County. And of course, we have people experiencing homelessness who are extraordinarily vulnerable for serious illness with COVID-19. So I guess, you know, I would ask that you focus on that and that you do everything you can to make sure that we're taking care of those people who have lost so much over the last few weeks and will continue to live through an economic devastation unlike any we've seen in our recent lifetime. I know there are, you know, people who go back, you know, many decades and have seen hard times with, you know, the wars and the world wars in particular. But, you know, for us, this is having a horrific impact, and one I feel that will be really, really hard for some of our families to recover from if we can't create a much deeper net of support that lasts long into this upcoming year.
Yeah, and let me add a plug on that front, Barbara. Let me add a plug of texture for our colleagues on the call. I mean, the philanthropic resources still pale in comparison to the federal stimulus, CARES Act, and other disaster relief. You know, some projected 200 billion plus coming to California. But so anything we can do to make sure that the most vulnerable and vulnerable communities have access to leveraging those resources, I think will be critical. And then an analysis of who's left out and who's left behind, the undocumented immigrant communities, many of the homeless, and focusing our direct dollar supports on those individuals and families who are left out of the federal response package. But with that, you've been terrific. Let's open it up to Q&A from the audience, but I'm not sure, Chris, exactly how that works. Is that?
I've been given a couple of questions here, Bob, so I'll throw them out.
So you can manage that part, Chris?
Yeah, don't go away though. You might have a good answer.
No, I'm here.
So often our high poverty communities may have different trusted messengers than mainstream media or certainly government officials. What can be done to ensure that an equitable and culturally appropriate outreach is successful?
It's a great question. I don't know, you know, it's hard to go back to the beginning of this pandemic here in LA County, but we had deployed hundreds of staff people who were trusted messengers in the community, our outreach workers, our health educators. We were doing dozens and dozens of community meetings at the very beginning. We were very focused in our Chinese community, in our Asian communities. There were lots of issues at the time around stigma and discrimination. The impact on Chinese businessmen was particularly acute. And the strategy at that point, because we weren't all staying at home, was we had hundreds of people out trying to actually do small community meetings, do door knocking, let people know, you know, both of the potential for COVID-19 to come and steps that people were going to need to take, but also really to counter issues around racism and discrimination that tended to crop up when we start the othering. You know, this is, you know, a Chinese virus. All of the horrible things that were happening at the beginning put a lot of our people out into the community. And we've been trying to figure out, you know, in this virtual world we're living, where, you know, some people don't actually have good access to that, what ought we be doing? We've really tried to use the fact that many communities have their own trusted news outlets. We have speakers in all different languages who will do briefings periodically to try to get information about the latest around COVID-19 and prevention efforts, but with somebody who speaks the language and comes from the community in which we're hoping they will be receptive to a message. And I think the other side of sort of that communications piece is really to identify who are the trusted. You know, so one thing is we can be messengers, and we can have some of our people who are wonderful and live in all of our communities be messengers. But the other thing is to really try really hard to make sure that all of the trusted people in our communities have good access to information. So some of you know, I mean, we do telebriefings. We do about 8 to 10 telebriefings every week for every single sector: faith-based, community-based organizations, early child care providers, large event venues, nursing homes and assisted livings, shelter providers, and those working with people experiencing homelessness. Like, we just every week elected officials, because we know that these are people close to the ground, to the work in the community, and they need really good information, because we're not going to get to everyone, but all of these other people, they're going to touch a lot more lives than we are. So we've really tried to, you know, we've not stopped doing that. We do them every week. You know, we divide it up between some of the senior staff here. So you're getting, you know, either me or Dr. Davis or Dr. Gunzenhauser We always have a medical expert. We always have somebody who's familiar with the content. And we try to make sure that we spend some time updating, but we also spend a lot of time listening. What are the questions? What kinds of answers do people need? What are the resources that people are asking for all these different sectors? Because these are the people that are closest to the work, the people who are providing WIC benefits, the people who obviously are from our faith-based communities, the community-based organizations that do both organizing but also deliver really important services. Our schools, we do meetings with the K through 12s, we do meetings with colleges and universities. So we're trying to sort of say, we cannot be the only messengers. We cannot be the sort of only experts here. Other people have to help us, and particularly other people who are going to be trusted in their community. So that's been one of our main strategies, and we've kept it up since January. I mean, we do these every single week. There's 8 to 10 of them. And we also set up a call center just for sort of managers of programs. It's a dedicated call line. We don't give it out. It's not for the public, but it's for leaders in the faith-based community. It's for the ECE leaders. It's for the superintendents and the headmasters and the principals. It's for the directors of the community-based organizations. And it's a concierge service line. You call it, you ask your questions, and somebody will get back to you and try to help you resolve your situations. So again, trying to make sure that with, sort of all the limitations we're living with, we respect and honor the work that continues to happen on the ground and the close ties that people have with the amazing institutions that support community life and still support community life.
I'll put a plug in to support ethnic media. It's a tough time for media in general from a fundraising standpoint. And I think the ethnic media outreach is so valuable in these times to augment what you're doing, the fabulous work that you're doing. The next question goes to your crystal ball, and I know we'd all like to have one, but you probably have the best crystal ball.
No, I don't.
When are you seeing the apex? Can you do your Governor Cuomo apex speech, or how do you see the waves coming after this? Will there be a second and a third wave? Can you predict anything for us?
No, what I can predict is that the draconian measures we've taken are making a difference. I mean, I think we have ample evidence now that says all of this distancing, all of these restrictions on our movements, all of these restrictions on us being with each other physically actually are helping to slow the spread. So I do now have confidence that we have enough evidence that says these are the right things to be doing. What I don't know is for how long. I definitely know this isn't going away in the next couple of weeks. We're not returning to normal at the end of April. That's impossible to conceive of, and I think would be a real mistake on our part. If we get, again, the luxury of watching what's happening in other countries, and we have to learn from that, that you cannot go back to what it was before for quite a while if you want to continue to slow the spread. And I'm trying to be a practical person, and I know that in general, like immunity, herd immunity, you got to get over 60% of folks, immune. We still don't actually understand issues related to immunity, what's the durability of the immunity you get from being already infected with COVID-19. We don't understand reinfection all that well yet either. We have no vaccine to date, and we don't even have therapeutic medicines that have passed their clinical trials and we know can help preserve life for people who are really sick. In the absence of that, we're going to have to hold steady on the public health tools we have, ask people to tolerate for a few more weeks this safer at home strategy, which really keeps us at maximum distance from each other. And then think about, I think, as we get to the summer months, what pieces of this can be relaxed with the purposeful intent of getting as many people back to work as possible. So where can you make adjustments in workplaces, in work routines, so that more workers can actually be gainfully employed? And I would say that's the task for the summer, is to work really hard to put as many people safely back to work. And I know, a lot of people say to me on our calls, like, when do we get to have a mass gathering? When do we get to hold a convention? I mean, these are all ways, these are jobs for people, and they're also ways we like to be with each other. And I think those days are still a bit off. And we're going to have a lot of patience because, we're not even close to having a large percentage of people here with any kind of immunity to this. So we're slowing the spread, we're keeping our healthcare system intact, but it's going to take us a while to actually feel like, all those gatherings aren't going to create new spikes for us, just like you said, those other waves.
The next question goes to testing. I think we've not been able to test as much. I'm guessing you have not been able to get as much out there. Can philanthropy help support the expansion of testing? And what do you think an expansion of testing might do to your numbers?
Yeah, that's a great question, and it is an area where we'd love support. We'd love support to create sustainable models around testing, though, is what I really want to say. I want to make sure we're doing testing in a way that actually is sustainable over a few months, and I want to make sure we do it in a way that makes sure that we don't see what we're seeing now, which is disproportionality in who's got access to testing. I don't have the data by race and ethnicity, but I do have it by neighborhoods. And wealthier neighborhoods people living in wealthier neighborhoods have been tested at a much higher rate than people who are living in poor neighborhoods. And we got to fix that right away. First of all, testing right now is still restricted to people who are symptomatic. And my sense is that we have symptomatic people everywhere. And that the barrier to testing is not because we have less symptomatic people who are poor. I absolutely see nothing that suggests that. I think we just don't have enough testing sites that have been set up in communities that are easily accessible to people who are living in communities where people have less income and are living in communities that are primarily communities of color. So I would say philanthropy could help us figure out what those models need to look like, how to quickly put those up, how to make sure that what's billable gets billed, and for those people who you can bill a service for. But the most important thing is to make sure we get to at least 10,000 tests a day. We're still probably only around 5,000 or 6,000 tests a day, and again, that disproportionality issue is going to haunt us. So any support that philanthropy wants to bring to bear on this, I think, would be particularly useful. And it wouldn't be necessarily a long-term investment. I mean, this would be something that we need to do over the next 3 or 4 months and do it well.
Dr. Ross, do you want to respond to any of these questions? I'm sure you have thoughts on all of them.
He has brilliant thoughts. So.
No, not at all. We got the right person answering the questions. Keep going. Are there any more, Chris?
The last question I see here is that beyond the issue of data, are there other strategies you might recommend for philanthropy to support our county in addressing racial disproportionality?
Yeah, again, my issue on racial disproportionality is it's not just around COVID-19. And so these root cause issues that have to do with racism and discrimination, like I would love for philanthropy to help us figure out what those investments look like. Because those investments will pay off now and they'll pay off in the future. And they'll really help us do what we needed to do in the first place, which is make sure that people who are African American, people who are Native Hawaiians, Native Alaskans, Native Americans, American Indians, don't bear the brunt of unfairness, historical unfairness and continued unfairness. If you look at the histories of the people I just mentioned, they have one thing in common, which is that, our country either spent many years trying to annihilate them entirely and or enslave them and or oppress them. And so, that legacy is all of ours to bear. But there's fixes to this. I mean, it's not inevitable. It doesn't need to continue, but it requires, I think, specific types of investments from philanthropy that are looking at sort of what are the long-term solutions to making sure that what we really have is a system that offers everyone access to the opportunities and resources that they need. It's not divide the pie equally amongst all people. That isn't going to work when you've had all this historical and continued disinvestment. So we have to really think about what does it mean to prioritize making this right. You gotta, I mean, some people call it reparations. I mean, I don't think it matters what you call it. It matters acknowledging that it's not a level playing field. The way to actually fix that is not to insist that we act as if it is a level playing field and we make investments across the board. I don't think that's going to work, and I don't think it's going to work around our response to COVID-19 either. I think we have to have a dedicated response that acknowledges the inequities that are playing out around who's getting sicker and who's more likely to die. And then we have to ramp up the way we support certain communities to make sure that we're doing everything we can to address the inequities that we see looming in front of us.
I think that's a great place to end. I mean, I do hope that we learn something from this crisis as a society, and that we actually see the reasons now so clearly as to why we need to take action.
Hey, Chris, just if I may, I just want to, on behalf of all of us in philanthropy, Barbara, first of all, I've known your work pre-COVID-19, but Barbara Ferrer, folks, has been on this issue of racial and health equity for some time, and so thank you for being a proselytizer and gospel preacher on that point, Barbara. And I just want to thank you for your leadership, your brand of humility, your courage, your strength. I know you don't want to wear the moniker of public health hero, but you are. Too bad. We're going to give it to you anyway. But I certainly, as an Angelino, am really proud to have Barbara Ferrer as the point guard in battling this unprecedented crisis. And I promise you, Barbara, we will take the comments you made about roles for philanthropy quite seriously. And I just want to thank you for each and every day. And your team, please. Let your team know at the Public Health Department know how much we appreciate what they're doing and what they're going through. And thank you so much for your leadership.
I thank you all for your leadership. I say, it can work in a lot of different places. We have great elected officials here, all who have worked collaboratively and are doing the right thing. I mean, you could be lots of other places where you can't say that. We have amazing philanthropic leaders and amazing community leaders, and that's getting us through this. So, thank you.
Thank you, Barbara.
Well, 200 of some of us second that, Rob. So thank you for laying some praise on our Director of Public Health. So thank you, both of you, for taking the time to be with us. I know this is a big ask of us, but it was one of our biggest draws. It was you being on this and being interviewed by the one and only Dr. Ross. So thank you all, also to all of you who listened in. I know many of you are deep in the midst of your own response efforts. So I thank you for what you're doing in the communities. So thank you to the SDG staff who have worked so hard to put together so many extraordinary programs this past month. We also know that it is vital for you as members to have an avenue to hear from experts like these, connect with each other, share learnings and resources, and ask questions. And we are honored to support you in that way. We hope you'll check out our website and join us for other upcoming virtual programs. And then until then, we wish you and your families the very best of health. Thank you all. Be safe.
Thank you. Thanks, Bob. Nice
Barbara,
talking.
appreciate you.
All right, have a good rest of the day.
Thanks, Chris.
Bye.
All right.